Welcome to Human School. I'm your host, Dr. Patil Armenian. After 4 years of college, 4 years of medical school, 4 years of residency, and 2 years of fellowship, I thought I was done. I did my time, got my degrees, and now I was just gonna live life. Well, think again. Some of my greatest schooling has come after my formal education was complete, and it keeps on coming. Join me at Human School, where we can learn together. I'm an emergency physician and medical toxicologist working at a large teaching hospital in California. I'm also a mom, wife, sister, daughter, and friend. Whether you work in healthcare or not, you too lead a busy life. Together, let's work on how we can thrive in all of our real-world roles. On this podcast, we'll dig deep into what it means to constantly learn and evolve, to be human. Every other week, I'll share some of my personal stories, interview inspiring people, and offer tools to help you learn more about yourself. Being on the front lines in the ER, you learn a lot about life and death. And though my philosophies were born in a busy emergency room, they can apply to anyone trying to live a joyful life here on Earth. Please listen, share, and subscribe to this podcast, available on Apple Podcasts, Spotify, or wherever you get your podcasts. Follow me on Instagram at Human School Podcast, and feel free to let me know what topics or guests you want to hear about. And if you like the podcast, don't forget to rate and review it. Hi, everyone, and welcome to Human School. As a disclaimer, I want to say that my stories do come from the ER, so they can be very intense, sometimes sad, and occasionally about death. So if you're not in a mental space for that, save this episode for another day. Also, I use the terms ER or emergency room and ED or emergency department interchangeably. It's really because most people outside emergency medicine know it as ER, even though we know it's not just a room. Today, I'm going to be talking about the origins and meaning of a mantra I say at work in the ED. There is no ego in the airway. What does this mean? Why does it matter? How does it apply to real life? How does it apply to situations outside of medicine? Let's get into it. I've been thinking about this topic for a while, and I had a recent case that brought it back to the forefront of my thoughts. Then, this past Thursday at our weekly department conference, we were discussing approaches to difficult airways, and I realized it's time. I think I'm going to have to get into this one. I'm an academic emergency physician, which means I teach medical students and residents who are doctors in training how to be full-fledged ER doctors, basically. We have educational conferences every week where we have structured teaching, but the vast majority of our teaching hours are at the bedside. Case by case, resident physicians learn and grow, and at the end of their 4 years of emergency medicine training, they're ready for anything. And I don't want to be so completely and utterly biased, but especially if you trained at my hospital in Fresno, you will be ready for anything because we see everything here. And I mean everything. There are a few places in the country that compare to us. What you're learning a lot of in residency is the nuts and bolts of things. How to take care of patients with all sorts of medical emergencies, how to get the right things done for your patients efficiently, when and how to get consulting specialists involved in your patient's care, all of the doctoring things you do that you can put on a list. Then at some point, the intangibles come in. For example, how to know if a person is sick or not sick, which we discuss in episode 9, Thin Slicing, Fast Decisions, and Intuition. How and when to choose your battles, when to ask for help. All of these ebb and flow at different stages of your career. I'm 18 years into emergency medicine, and I still get hung up on that when to ask for help conundrum. I've always had a problem with asking for help. That's different than offering help, which I've had no issues with. But for me to ask? For many years, I saw it as a sign of weakness. In addition to seeming weak, I had this completely unfounded assumption that no one can actually help me with anything. Ridiculous, right? I have this memory of being an undergraduate student at UCLA, the University of California in Los Angeles. In the summer, I had just become the photo editor of the Daily Bruin. which is the school newspaper. The Daily Bruin, at that time, we were all really proud to say, was the newspaper with the third highest circulation in Los Angeles. And it was a big deal for me. It was my life back then. And I spent way more time in that newsroom than in studying for my actual classes. Every year, we had this big issue called the registration issue, which was like the first issue of the new school year. It was big for us, usually as thick as the Los Angeles Times. And yes, this was in the days where everyone read print newspapers. Between myself, my two assistant photo editors, and a bunch of photographers, we took all of the photos for each issue. This was actually the last year that all the photos would be shot on film before going digital. So I also managed darkroom staff who would develop our film in the darkroom we had right there in our office. The editors and I would then sit for hours at a light table with a loupe, staring at all the photos and manually scanning in a select few for each story before whittling it down to the final images. Now, this specific issue required about 5 times the work as a normal issue. And in the week leading up to it, everyone was out of town. Like my other photo editors, almost all the photographers, they were all gone. I ended up pulling 2 all-nighters in a row in the Daily Bruin office to get everything edited and ready for print. That means I was awake for over 48 hours. And in the middle of that time, I drove to the Rose Bowl in Pasadena, which was about 45 minutes away from campus, to take photos of a football game that we needed for the issue. I was a tired, miserable wreck by the end and vowed that I'd never do that to myself again. But I didn't really learn my lesson then because I didn't know how I'd never do that to myself again. Looking back now, I know that someone else could have covered that football game. Some of our veteran photographers were around and probably would have jumped at the chance to go to that game. But photographing a UCLA football game was so prestigious, just so cool, that I didn't want to give up my spot. And that was the thing that sent me into peak exhaustion later. And of course, staying up for 2 nights in a row. I'm sure the exhaustion was making me work less efficiently. I probably could have slept a little and been more efficient during the day to get the tasks done. Maybe the lack of sleep and being able to do multiple tasks on your own was preparing me for medical education. I often look back fondly on my days working at the Daily Bruin and think that was my best preparation for being an emergency physician. The constant buzz and activity of a newsroom with teams working together to meet hard deadlines is very similar to the ED. As a photojournalist, I could take pictures of a news story, but in order for my photo to get published and make sense, with me were a darkroom tech to develop the film, a photo editor to choose and edit the best shots and write the captions, a journalist to research and write the story, a news editor to edit the story, a copy editor to edit further and write the headline and subheadline, a designer to lay out the story, additional teams to get it ready for online and print publication, an editor in chief to oversee the content of the entire newspaper, and a managing editor to make sure it all gets out on time. Now, I'm sure I'm missing people, but this was my first time working with a big team, and it was both fun and difficult in equal measure. Over 20 years later, the stakes are higher. Because now, when I work with a big team, it means something serious is happening. Like some shit is going down. It's something at the edge of life and death. This would be a resuscitation, which is when we are working to help a very sick person of any age, sick from any possible reason you could think of. How many people can you put in a resuscitation room? You're only limited by the size of your room. How many people do you want in a resuscitation room? That's a very different question with a different answer. It's completely normal to have 10 people helping with a resuscitation. Certain cases bring that number up to the 15 to 20 range. I was talking to my friend Diane, an ER doctor who works in a rural hospital, and even in her resuscitations, there's a minimum of 6 other people in the room. Everyone comes out of the woodwork to help when someone's very sick. What I'm trying to say is that I'm never working alone. That's one of the parts of emergency medicine that I love. None of us can do it alone. and each person on the team brings a valuable piece. The following story gives a good impression of what these cases are like and how many people it takes to save a person's life. It's intense, and I will talk about blood, so again, if you're not in the mood, stop listening now. So I hear it called out overhead: trauma activation 5 minutes out. My first step was to walk to the radio room and ask the nurse what's coming in. She promptly said gunshot wound to the face. I walked the 20 steps to our main trauma resuscitation room where the team was getting ready. I mean, they're so awesome. Everybody works like a well oiled machine. The only thing I needed to say was, set up 2 suctions, please, instead of the usual 1. With a gunshot wound to the face, my main concern was the airway, since a bloody airway can be life threatening while also being very difficult to secure. The airway is the passage by which air reaches a person's lungs. So the nose and mouth, throat, trachea, which is a tube that branches off into the lungs, these are all the airway. We had our suctions, airway equipment including direct and video laryngoscopy, difficult airway tools, and a cricothyrotomy kit available. Now, I know those are all words you may or may not understand. It's just a lot of tools. Now let me list the people in the room, which does not include the CT techs, X-ray techs, phlebotomist, and clerk who are just outside the room. So we got 3 nurses, 2 respiratory therapists, an EMT tech, the ED pharmacist, the trauma surgery team, including the trauma surgery attending physician, 3 residents, 1 PA, a few medical students, then the ED senior resident, and me, the ED attending. A lot of people, right? At our level 1 trauma center, the ED resident and attending are responsible for the airway and calling out the primary survey, which is the initial examination of the patient to find the injuries. I know teams are organized differently at other hospitals, so your hospital might be different. The team, of course, really matters, and I get along with the trauma surgeons well, so our resuscitations tend to run smoothly. On this day, the trauma surgery attending happened to be someone who had finished her residency with us, then left to do a subspecialty fellowship for a few years and had just returned back as faculty. She's known for being cool, calm, and straightforward. I'd liked her as a resident, and this was our first trauma activation together since she got back. The medics rushed in with the patient, who was sitting up on the gurney holding a towel on his mouth. He was saying, "Help me," over and over again, which was actually a good sign in that he was able to breathe. This is the first step of our ABCs, which I will discuss shortly. The towel was soaked in blood, and we transferred him over to the gurney while sitting up. He couldn't lay flat due to the blood pooling in his mouth. In the field, as soon as the medics had tried to lay him flat, he began choking on his blood. So we weren't about to give that a try. That's a pro tip right there. If paramedics bring in a patient who seems to be in an awkward or not ideal position for what their reported condition is, know that they did that for a reason. Ask the paramedics why the person's in that position. Trust me, they've done it for a really good reason. The tech quickly got him on the monitor and took a manual blood pressure. His vital signs were fairly normal. Now we're in the midst of what we call our primary or initial survey. For those of you that already know what all this means, I'm sorry, but I have to explain it to my sister. This begins with the ABCs, an acronym that applies to all of our resuscitations. A is for airway, B is for breathing, and C is for circulation. You need those 3 to live, so if there's a life-threatening problem at any one of those 3, we have to stop and address it immediately. Quickly surveying his face, we could see 1 gunshot wound just behind his left ear. There was no second skin wound. What was going on was that the tongue was lacerated from the bullet, and his mouth would fill with blood as soon as we suctioned it. When we saw him rolling in holding that blood-soaked towel in his mouth, we'd actually already called out that we were going to intubate him. The medication nurse had pulled up the necessary medications to adequately sedate the patient and then paralyze his muscles so that we can intubate him or put a breathing tube into his trachea. The respiratory therapist had all the intubation equipment ready. I called out that we had a cricothyrotomy kit at the bedside, just in case we had to put a breathing tube directly into the trachea, through an incision in the neck. I like to be prepared for anything. If anyone questions me, even with a look or a raised eyebrow, I always say it's to ward off the evil spirits. And they immediately agree or say, of course, and get the equipment ready. I feel this applies to everything really, life and the ED. The more prepared you are, the less things tend to go awry. Because he was shot in the face and neck area, we truly didn't know the extent of his injuries. That meant that the spinal cord in his neck could be injured, and someone had to hold his head in cervical spinal precautions during the intubation. Often I'll do that for one of my residents during a trauma case. Our residents are excellent at airways and don't usually need any help. This was an exceptionally bloody airway, though, and I wanted my full attention to be on securing the airway and helping the resident. So I called out to a junior resident to hold the patient's head. Now, at the head of the bed was the ED resident. I was standing just to her left. The trauma surgery attending was right next to me, and the junior surgery resident was squeezed in there, kneeling down, holding the patient's head still. We let the patient know that we had to put him to sleep in order to help his breathing and to stop the bleeding. The patient nodded, okay. The nurse pushed the medications and we laid the patient down when he got sleepy. Immediately, the 2 suctions were necessary as we tried to suction enough blood to find the epiglottis. That's a landmark we need to see to know where to put the breathing tube. The ED resident first used the direct laryngoscopy blade, got a quick view of the epiglottis and vocal cords below, but he was bleeding too fast, and the suction catheters could not keep up. And just so you know, when we say blade now in this setting for laryngoscopy, it's not a knife. It's like this handheld metal object that is really helpful to kind of get the tongue and other tissues out of the way so you can get a good view. She switched to the video laryngoscope for her second look, which was worse because the small video camera at the end of the blade immediately got covered in blood, making the camera useless. This is a well-known issue and why we often prefer direct laryngoscopy in a bloody airway. Instead of switching back, she looked at me and said, "Do you want to take a look?" Which is code for help. I need help. The patient was bagging okay and his oxygen saturation hadn't dropped, so she could have actually tried again. But the blood, there was so much blood. He was hemorrhaging out of his mouth and we didn't have much time. So I said yes and grabbed the laryngoscope in one hand and the suction catheter in the other. Meanwhile, the trauma attending was continuously suctioning with the second suction catheter. I took a look and there was just, again, so much blood. I called out, "Prep the neck," and the trauma surgeon grabbed a ChloraPrep soap to start cleaning the skin. I think I see the epiglottis, but no vocal cords, and insert the endotracheal tube under the epiglottis where the vocal cords should be. Typically, in an intubation, you see the epiglottis, then either lift it up directly or indirectly by lifting up the surrounding tissue. When the epiglottis lifts up, you see 2 shiny white vocal cords below, and it's like the sun breaking through the clouds on a rainy day. Like, ha, there it is. Because once you see the cords, you know you can get that airway. I didn't see the cords in this case, so I wasn't sure if I was in the right spot. The respiratory therapist started bagging the patient, and with the first 2 breaths, our end tidal CO2 didn't rise yet on the monitor, and the color on the end tidal CO2 detector on the bag didn't change. So I just pulled the tube right out. Later, I would find out that as the RT was pulling the tube, the color did change, so I was in the right spot. Why I didn't listen to the lungs or wait one more breath just shows the sheer level of adrenaline in the room. I went back in for a second look, this time even more hyper-focused because I knew it was my last shot. The airway was filling up with blood quickly. I suctioned some away and could see the epiglottis, but again, no vocal cords. As I was holding the tube, I loudly called out, "Cut," as in cut the neck and do a crike or cricothyrotomy. Just as the surgeon lifted her scalpel to begin, I put the tube under the epiglottis. She paused to see if I was in. The first breath, no color change. With the second breath, there was a color change. Seeing that blue change to yellow, everyone in the room began to breathe again. His SATs never dropped below 89%, and now they were climbing steadily. But it wasn't over. He was still bleeding profusely, and there was almost 1 liter of blood in the suction canisters. Imagine pouring out 1 liter of blood from your mouth. Now the trauma surgeon sprang into action, feeling inside the mouth for a hole, for a spot where all the blood was coming from. She felt it in the back of his tongue and put her finger in it, stopping the hemorrhage. With her hand on the left side of the mouth and mine holding on to that endotracheal tube for dear life, both of our fingers were hurting from the patient's sharp teeth digging into them. We looked at each other and I said, "I'm happy to see you back." And we laughed. Now we could call the oral surgeons in for help, get an x ray to confirm tube placement. She applied direct pressure on that tongue wound until they arrived. By that time, the bleeding had stopped, and we were able to take the patient to the CT scanner to get a better grasp of his injuries. I felt like I was at the head of that bed trying to intubate for such a long time. Later, I asked the nurse who was record keeping, "How long did that take?" Only about 1 minute had passed from me initially taking the blade to then finally securing the airway. Time really slows down when you're living in the present so wholly. During that time, I was thinking of nothing else other than getting that tube in the right spot. Everything else dissipated, and the present moment was the only thing that mattered. And that's how you stretch time. This case stuck with me because of a few things. One, I've often thought about how much time stretches out when we're focused, especially when we're focused on a sick patient. But this case really solidified that. In all honesty, I felt like 10 minutes had passed, and when the nurse told me it was only one, I was in genuine shock. When you're living in the present, time just changes. Two, this was a calm room. We all knew our roles, and with how quiet the room was, you wouldn't know there were about 16 people in there. You can really think and work better when the vibe is set correctly. I don't know how else to say it. But especially as ER doctors, we're kind of like the vibe setters in the room. If we lose it, everybody else is going to lose it too. So we kind of have to be the most calm person in the room to get things done. Three, people asked for help at the right time. This was an exceptionally difficult case, and the resident asked for help when she needed it, and I too asked for help. Remember, I told the trauma surgeon to start cutting the neck. That's how awful the airway was looking on my end. I know my past self, who was a little cockier and a little more egotistical, thinking that if I didn't get the airway, I was a complete failure. And so I would have had the cricothyrotomy kit at the bedside, but I wouldn't have asked for the neck to be prepped. I wouldn't have told anyone to start that invasive procedure because I would have been overly cocky, like, I'm going to get this airway. Then, if I didn't, we would be scrambling to prep the neck, get the kit out, etc., lost valuable time. I just so happened to get the airway in the end, but as time stood still, I took my ego out of the picture and focused on the patient and only him. And all he needed was an airway. Doesn't matter who got it or how. He just needed to get oxygen to live. How did I get to this point? It's a fine line, really, knowing how to do something and learning how to do it exceptionally well, and also asking for help when needed. Because you actually do have to do things on your own to learn how to do them the best. You still have to become an expert at the procedure. But the asking for help part, I learned about asking for help the hard way, as I learned everything. When I was in training, I had this idea in my mind that asking for help was a total sign of weakness. I didn't like other residents coming into my resuscitation rooms because I didn't want anyone, quote, taking over my room. If I had a difficult airway, I would do whatever I could to not ask for help. And if someone had to bail me out, I thought I was a total failure. But I was also lucky. I didn't have very many truly difficult airways when I was in training. As a new attending, I felt the same about other attendings coming into my resuscitation rooms, especially if the advice was completely unsolicited. I wanted them out. Now I realize that a lot of us process information by speaking about it out loud, and that we genuinely want to help each other with cases. And more minds are helpful. Fresh perspective on a case you're stuck on can be invaluable. I don't mind the opinions and feedback of others anymore because I just know like what to take and what to put away for later. And when it comes to airways, they've been my biggest teacher because I had a series of very difficult airway cases come to me in my early attending years. Every February, actually, for about 4 years on the dot, I would get some terrifying case. Each was someone with an extremely large swollen tongue or another issue which was completely inhibiting our access to securing their airway. In each case, the resident would be unsuccessful, then I would try, and I would be unsuccessful. Then one specific colleague of mine would come in and get the job done. Now, this is someone who is extremely adept at procedures, especially these, and has a few more years of experience on me. But I got to the point where I really felt embarrassed, like this person must think I'm totally incompetent. And we all kind of have imposter syndrome, so this was not helping my imposter syndrome. And, that wasn't the case at all. I slowly realized he would call me for help or ask for my advice on other types of cases because we all have our specialties or the things that we're really good at. It was actually an equal exchange. Then one day, thinking about this topic, this sentence just popped into my head. There is no ego in the airway. It doesn't matter who gets the airway in the end. What matters is that the patient has an airway and can now live. Time stands still. Everyone in the room holds their breath for a second, and someone does a procedure to get oxygen delivered to the patient. It's the patient's life that matters, not who put the tube in the trachea and how. There is no ego in the airway. 2 weeks ago, I was called into a room to intubate a patient that was crashing. It was another very difficult airway due to some anatomic abnormalities, and the first person tried, but the tube would not go in. I gave it a try, and it was nearly impossible. So while I was trying again and getting all my adjunct tools ready, I called for help. I knew that other attending, the one who'd helped me out many times before, was actually in the department, and I specifically asked for him. Time stood still again while I stared at the vocal cords, trying to push the tube past something that felt like it was blocking its path. But I was comforted, knowing help was on the way and that we would all work together to do everything we could to secure the airway and save this person. I pushed back whatever that little block was and knew the tube was in the right spot. As I looked up, I saw about 5 ER doctors power walking towards me, all ready to help, including the one I'd asked for. I gave everyone a thumbs up, and they U-turned back. I later told that other attending, I asked for you specifically because I knew you would get it. And knowing who was working with me and how amazing the entire team on was gave me the comfort to push past that obstacle and get the tube in. Until I understood that there's no ego in the airway, I really wasn't doing the best thing for the patient. Now I'm trying to carry this into my real life too. It's hard, but it's okay to ask for help. Just like it's okay for others to ask you for help. It's a universal back and forth, and it all evens out in the end. None of us are meant to do big things alone. It's just not in our human nature. So don't be afraid to ask for help when you need it. Thank you, everyone, for listening, and I'll see you next time. Please like, subscribe, share, and download the podcast. And again, you can find us at Human School Podcast on Instagram. I'd like to thank Dr. Zach Effron for the theme music. And I'd just like to make a general disclaimer that any of the institutions I work for, including Community Regional Medical Center, UCSF Fresno, and American Ambulance, have nothing to do with any of my thoughts or opinions. And so we'll kindly leave them out of this. Thanks, everyone. See you next time.